Good afternoon, everyone. My name is Shannon Kupka with Comagine Health. I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to support your efforts and provide you great ideas on caring for your residents in a 30-minute time frame to accommodate your busy schedules. And they're brought to you by the Comagine teams from Idaho, Nevada, New Mexico, Oregon, Utah, and Washington. We appreciate you joining us today, and we will be recording and posting this session for later viewing. A few housekeeping details before we start. Please go ahead and let us know who's on the webinar today by entering your name and facility in chat, as well as the names of any folks joining you so we have an accurate head count of participants. And please make sure that you're chatting to all panelists and attendees. Your cameras and microphones are muted. If you'd like to ask a question, please enter it in chat and we will facilitate a question and answer session at the end of the presentation. So we are delighted to have Dr. William Simonson with us today to talk to us about medication management to prevent, detect, and report adverse drug events. Dr. William Simonson is a board-certified geriatric pharmacist licensed in Oregon, Virginia, and Rhode Island. He is active in pharmacy practice, education, and research, and is involved in a variety of practice settings, most recently serving as consultant pharmacist at the Hazelden Betty Ford Foundation Springbrook Substance Abuse and Recovery Center in Newburgh, Oregon, and at the Good Samaritan Society Eugene Village Skilled Nursing Facility in Eugene, Oregon. Dr. Simonson received a Bachelor of Science degree in pharmacy from the University of Rhode Island and Doctor of Pharmacy degree from the University of Michigan. He also completed a clinical pharmacy residency at the University of Michigan Medical Center in Ann Arbor. Simonson has served as tenured faculty at Oregon State University College of Pharmacy as an associate professor of pharmacy practice and adjunct associate professor of medicine and geriatrics at Oregon Health Sciences University in Portland, and presently has a part-time faculty appointment with the Oregon State University College of Pharmacy. He has more than 200 publications on pharmacy and medication-related topics, is the author of 2 books, and has delivered more than 800 local, national, and international scientific and professional presentations. So I will now turn things over to Dr. Simonson, and let's do a quick test audio with the group. Dr. Simonson, can you say hello?
I can. Hi, Shannon. Thank you for the introduction.
Good. And can somebody chat back to me, please, and let me know that you can hear that the audio is good? Yep. Okay. Dr. Simonson, you may get started.
Great, thanks. And by the way, I have my chat window open. If anybody has any comments or questions during the presentation, please just, I'll keep looking. As Shannon mentioned, I'm a consultant pharmacist. I've been doing it for a number of decades, actually since before there were consultant pharmacists, before the regulations. And it's really been a pleasure. I'm very glad to see that it's a really mixed audience, including pharmacists, infectious disease people, coffee people. I'm not currently consulting at a facility. I was until about 9 months ago, when the pharmacy ownership changed hands and the consultant changed hands, but I'm looking forward to getting back into practice after the pandemic because I just love working with the interdisciplinary team. So my presentation, I'm going to talk a lot about the interdisciplinary aspects of the topic, and the topics primarily, I'll go through a few definitions first, and I'll talk about the concept of high-risk medications, and then I'll focus on the 3 high-risk categories in the Comagine Health Initiative. I'm not going to be reviewing the initiative, but I'm sure there's plenty of opportunities for you to do that in the upcoming days and weeks and months. And then I'll close by talking about some of the points that state surveyors look at as far as evidence of systemic medication safety. And definitions, these come from the CMS document, Adverse Drug Event Trigger Tool. And this is a document, the reference is there. It's basically designed for surveyors. So it's really nice to be able to look at the other parts of the document, and you'll know what the surveyors are looking for. But they start out with definitions. The first one is not specifically drug-related. An adverse event is untoward, undesirable, and usually unanticipated event that cause death, serious injury, harm, or the risk thereof. And that could include falls, it could include a burn from excessively hot water, et cetera, or it could include medication issues. A lot of these terms, when it comes to drug reactions, et cetera, are confusing and conflicting sometimes, and they differ depending on what document or what society writes them. But adverse drug reaction, according to CMS, is harm directly caused by a drug at normal doses. So this is sort of like stuff happens. Maybe someone takes a normal dose of diphenhydramine, Benadryl, and they get drowsy. Well, I guess you could consider that an adverse drug reaction if it caused them to perhaps trip and fall. Or you could call it a therapeutic effect if you were using the diphenhydramine for sleep, which I don't recommend, but it is used for that purpose because it does cause the drowsiness. So an adverse reaction, basically we think of a drug at a normal dose. And in the elderly, there's more likely to be adverse reactions at normal doses. An adverse drug event, which is our focus, is an injury resulting from a drug-related medical intervention. And then I wanted to talk about the umbrella issue, medication-related problems. This is something that pharmacists are probably a little more familiar with as far as our general lingo. But it's an event or a circumstance involving a patient's drug treatment that actually or potentially interferes with the achievement of an optimal outcome. And let's look at what medication-related problems are. Could be a medical, and these are basically, theoretically, any medication problem can be categorized in one of these 8 categories. Sometimes you have to, it's a little bit of a stretch, but medical condition that requires new or additional therapy. Patient is taking unnecessary drug given the current condition. An example of that could be maybe they're taking a proton pump inhibitor and they no longer have GERD, or they no longer have reflux. That's a really common one. So indications change, drugs may not, and maybe they should. Maybe the wrong drug for the patient's medical condition, correct drug, dose too low, correct drug, dose too high, an adverse reaction, drug interaction, and patient not taking the drug correctly. So some of these medication-related problems may result in an adverse drug event, some may not. Sometimes if you're using the correct drug and the dose is too low, we're less likely to have an adverse drug reaction, but a lot of these can actually conflict. If, for example, if somebody has a medical condition that requires new therapy, and that therapy would have caused an adverse reaction, and for some reason they didn't get it, well then the adverse reaction was prevented. So I don't want to complicate things, but basically all these terms kind of fall under the umbrella of medication-related problems. When I talk about high-risk medications, and there's many, many groups of high-risk medications. Certainly the ones we're going to focus on today are anticoagulants, opioids, and hypoglycemics, but there are many others. We're well aware that psychoactive medications are a strong focus on trying to decrease their use. I'm involved with the Oregon Partners in Dementia Care. We're working with facilities to constantly reduce the use of psychoactive medications. And those of you who are on psychotropic drug committees, for example, you know that's a big part of your activity. Anti-seizure medications are high-risk drugs. Often they require serum level monitoring. Some of their pharmacokinetics are pretty complicated. There can be drug interactions, so they're high-risk meds. NSAIDs by themselves can cause a lot of toxicities, anything from renal dysfunction to gastrointestinal irritation, and many others. And that document, the CMS document for surveyors that I cited earlier, a link on that if you want to see a number of the high-risk categories. And you can also look at the Beers criteria. The 2019 is the most recent version that reviews many of the high-risk categories. But we're going to focus on anticoagulants, opioids, and hypoglycemics. Anticoagulants, and I'll review each of these categories, each with a couple of slides, talking about why they're high risk and what are the issues. Anticoagulants, we primarily talk about parenteral or oral. Parenteral, the one that historically was the big issue was heparin. And when I was going through my training in my early practice, heparin was very common. unfractionated heparin. Basically, it required frequent monitoring of what we call the partial thromboplastin time, not the prothrombin time, which is what's used to monitor Comagine or warfarin. But the PTT was monitored frequently. Heparin had a short half-life. It was really challenging monitoring the PTT. Bleeding problems were common. I'm sure that inappropriate dosing, underdosing, and therefore clotting problems were common. And gross dosing errors were possible. There were different strengths of insulin, and even as recently as a few years ago, there was a very public tragedy where some movie star, their child was in a hospital and the wrong dose was given, and they got a dosing error of 1,000 times normal or something like that. So this was really a problem. Well, low molecular weight heparins came about, Lovenox, for example, and that was revolutionary because it was an anticoagulant as effective as heparin, but you didn't have to do a PTT. In fact, you didn't have to do anything. And in addition to that, bleeding problems were rare. You still have to monitor for bleeding problems, but it solved so many problems that we had with heparin. So it was really a pharmacologic advance. Oral agents, which are the ones we're primarily dealing with in our facilities, they're basically two categories. Most common, the vitamin K dependent anticoagulants, which primarily is warfarin or Comagine. And basically the way that works, it inhibits the production of vitamin K dependent clotting factors. And it's a challenging drug. Bleeding problems are common. And it's joked that it's a rat poison. It is a rat poison, or at least chemical forms of the drug are used as rat poison because they cause bleeding in the rats and it kills them. It's an interesting drug. It was discovered in the late 20s and early 30s in Wisconsin because cows were eating moldy hay or moldy clover, and they were having bleeding problems and dying of bleeding. And some smart person figured out that it was warfarin. So then they challenged, we found the warfarin and we're able to concentrate it and purify it. Now it's used therapeutically. And warfarin stands for the Wisconsin Alumni Research Foundation, just a little party rat fact. Warfarin, Wisconsin is where it was discovered. But it's challenging. We need routine monitoring of PT-INR, and there's an antidote, vitamin K. Then we have the direct acting oral anticoagulants. And for example, Eliquis, Xarelto, Pradaxa. And rather than affecting 2, 7, 9, and 10 clotting factors, it affects and inhibits factors either 2A or 10A. They have short half-lives. There's a predictable dose response, unlike with warfarin. The dose response is very similar between patients. They're much safer, as studies are showing now. Routine laboratory monitoring is not required, and it's not even available. And it's not necessary. So it's interesting. It's taken a number of years for clinicians to finally, I think, start to grasp the concept of using these drugs over warfarin. And there's still quite a ways to go. And that's a whole nother hour presentation. Why is warfarin at high risk? Well, I've kind of reviewed it. It's close monitoring of PT-INR is required. Monitoring does not always take place in a timely manner. Look in your facilities. Sometimes, problems have occurred, and look back in your own incident reports, and you'll know that monitoring the PT-INR is crucial. Maybe results are not reported or not documented in a timely fashion, and then we don't know what dose to give. So complications are easy to occur. They're frequently occurring. Patient response varies depending on the concurrent condition, drug interactions between drugs, between nutrients, and 100% compliance is required. Compliance in taking the medication, the proper dose, proper patient, of course, avoiding drug interactions, drawing the labs, and reporting correctly and quickly. When bleeding occurs, there are clotting factors, and basically the clotting factors have depleted when bleeding occurs, so the body then has to make more clotting factors. And there's a rescue medication, vitamin K, It rescues the patient from the bleeding, but it complicates therapy. It basically competes with the warfarin, and the body is once again able to manufacture clotting factors, but it takes a while for that to happen, and the patient may then be unprotected and may develop thrombosis. So a lot of times, clinicians like to avoid using the vitamin K, even if the patient's INR is getting up into that range that makes you really nervous. 6, 8, 10, you know, it's different clinicians have different thresholds where they're willing to order vitamin K. Here's a couple of quick case studies. 75-year-old man had very stable PT-INR on a consistent warfarin dose. All of a sudden, PT-INR dropped to subtherapeutic value. I'm not going to give people a long opportunity to respond. If you have any issues, questions, ideas, put them in chat. But because of our time, I'm going to tell you what happened here is this is a true case. This man had seen an article on spinach and the value of eating spinach. He switched to a high spinach diet, and that caused a drug-nutrient interaction, and his PT dropped to a subtherapeutic value where he was no longer being protected. Another one, 80-year-old female with a PT-INR stable. She was on consistent warfarin, and she developed a UTI, was placed on an antibiotic, and then the PT-INR rose and was an issue. And I'm just kind of checking on my slides here. There we go. And what happened, she was placed on an antibiotic, and antibiotics can cause drug interactions. And they can raise INR, they can lower INR. I've seen both occur. So typically, if an antibiotic is ordered on somebody who's receiving warfarin, I usually within 2 days, I say, let's get another INR and see what's happening. Finally, an 82-year-old female had been receiving warfarin and dosing based on PT-INR. Oops, there you go. Pharmacist requested a new PT-INR, and it was found INR was reported as 6. This was a situation that I saw, and basically the repeat INR order had been missed, and the resident didn't have an INR for 2 months. I contacted the doc, and he goes, wow, it's crazy that happened. That wasn't supposed to. And luckily, the resident did not have bleeding. Opioids, another high-risk category, includes morphine, codeine, oxycodone, hydrocodone, many more, as you know. These drugs bind with and stimulate naturally occurring opioid receptors. And then there's pain relief, along with a lot of adverse drug reactions and adverse drug events, potentially serious, potentially lethal. And you know the problems that can occur: somnolence, delirium, respiratory depression, death. Why are they high risk? A lot of different reasons for high risk of the opioids, especially dangerous with PRN use. In patients who are opioid naive, that's a real risk group. In combination with CNS depressants, patients with abuse history and opioid tolerance can put them at higher risk. Dehydration, severe pain, head trauma, all of these are reasons to make this drug category higher risk. There are rescue medicines, and the one we primarily think about is Narcan. You're probably very familiar with pharmacists now dispensing Narcan, patients having a supply, and family members, they can administer it to their loved ones if it's needed. The effects are reversed almost immediately, can be very dramatic. It lasts 30 to 90 minutes, but unfortunately, the effect of the opioids may last as much as 90 minutes or more. So you really need to monitor that patient, and they may need a repeat naloxone dose, because the naloxone may wear off, but the opioid effect may continue and the patient may go back into respiratory depression. A couple of quick case studies. A prescription was written for a 75-year-old man for fentanyl. The initial prescription, he was a 100 microgram per hour transdermal system. This was brought to the pharmacy. Pharmacist called the physician, and pharmacist refused to fill the prescription. And actually the physician said, I'm the doctor, you fill this. And the pharmacist said, doctor, if I fill this patient will die. My friend was a little dramatic, but he was probably accurate. The patient had not been on an opioid. And if fentanyl at this dosage is started in an opioid naive patient, pretty good chance that they will die. 92-year-old female nursing facility resident, 96 pounds, taking alprazolam, Ambien, diphenhydramine. There was an order for oxycodone, pretty reasonable order. Then she quickly developed, within 48 hours, unresponsiveness. Well, this is a little old lady, small body size, drug-drug interactions, and not surprising that she could have complications. Hypoglycemics, the last category, and we're kind of running up against the clock here. There are many different types of insulin with different durations of action. There are many oral products, combination drugs. It's really exciting how the developments in new anti-diabetic agents. Adverse drug events are primarily due to hypoglycemia, including all of the below: falls, shakiness. You're familiar, I'm sure, with the signs and symptoms of hypoglycemia. And these are drugs that are at high risk because of their half-lives. The use of sliding scale complicates things. Change in nutritional intake complicates things and requires different dosages. There is a rescue medicine, glucagon. Glucagon basically strongly opposes the action of insulin and promotes the formation of glucose in the liver. And it's a rescue med, works pretty dramatically. There are other rescues, of course, giving crackers and peanut butter or whatever is the protocol in your facility. But glucagon is the third rescue drug of these three that we're discussing. A couple of quick case studies. A nurse preparing medications in the med room remarked to the pharmacist, that was me, oh my God, I just drew up the wrong insulin. She was supposed to get regular, but I drew up a long-acting product. And what happened is each of the vials were kept in plastic prescription vials, and they were labeled on the outside of the plastic vial, and the product had been switched. Just like using different colored caps, it's real easy to make an error and choose the wrong drug. Fortunately, she triple-checked and prevented what could have been a tragedy. 90-year-old female taking glyburide, 5 milligrams once a day, became lethargic, shaky, had blurred vision. Low blood sugar was found. Well, glyburide has a long half-life. It's a Beers drug. It's on the Beers criteria. Not surprising that she would have a prolonged half-life and a severe reaction. In the CMS document that I showed you, basically it talks about monitoring, communication, and safe administration as kind of domains that surveyors look at. These are surveyor guidelines, and let's look at monitoring. Because you know what the surveyor tools are, this is a surveyor tool. It's like taking an exam and already having the questions. If you know what the surveyors are looking for, you should be able to solve these issues before they occur. So for systems of monitoring, the surveyors will look and they'll see, can the staff, family, or resident describe the signs and symptoms of the adverse effect? Is there evidence that the facility routinely monitors medication-related lab results? This is not rocket science. These are all things that we should be doing, but this is a great review, and your QAPI committee or other committees that are working on this, QI committees, et cetera, I guess QAPI is the primary one, would be very, behoove them to be aware of these things that surveyors are looking for. Look at the next one, systems for communication. Evidence for a system of ensuring handoff communication, which includes residents' clinical status and the time of the last PRN drug. Evidence of systems to ensure that routine and panic value lab results, especially the panic value, including the finger stick blood glucose, are communicated. Routine education. Does the facility routinely address pharmacy recommendations? Please do. Pharmacists are really smart when it comes to drug therapy. I'm a strong advocate of pharmacists in facilities, being part of the QAPI committee, part of the team, serving on the psychotropic drug committee, et cetera. And if the surveyors see you're not using your pharmacist correctly, they're going to take note. And evidence that the medication-related lab values are integrated into the record. Finally, systems for safe administration. Is there a system to ensure extended release formulations are delivered correctly, that they're and not crushed? In one facility I saw an order, give all medications by mouth, even those that aren't supposed to be crushed. Oh my God, the surveyors would love that. Evidence of a system to identify and notify nursing if multiple medications containing acetaminophen are ordered, etc. Take a look at that reference. The link is on that earlier slide. And you'll know the questions, the items, the domains that the surveyors are looking for to help you avoid adverse drug events. I'm out of time. I'm going to pass this over to Shannon. Wow, this went quickly. This is fun. Shannon, take it away.
Great. Thank you so much, Dr. Simonson. So while you're thinking of questions for Dr. Simonson, and I encourage you to go ahead and enter those in chat now, I'd like to briefly tell you about our new Comagine Health initiative. We are working on a partnership to reimagine healthcare, working with providers across all care settings on issues like improving patient safety, infection prevention, adverse drug events, improving access to behavioral health, and improving care transitions by reducing admissions, readmissions, and emergency room visits. Providers who join the partnership receive a range of support, including expert coaching, technical assistance, education and resources, and access to their performance reports, all at no cost to you. So joining is as easy as putting your name in chat. And if you found benefit from our hot topics today or other days, the prevention gems and newsletter and other things that we offer, please feel free to join us. We'd love to have you. I'm gonna read any, let's see, we had one comment. Adrian, thanks you very much. Dr. Simonson, so much great information. What kinds of questions do you have? We've got a couple of minutes left.
I'll just make a quick comment while we're waiting. It may be people are shy, but I've really enjoyed my work on the QAPI committee, and I really feel that as a pharmacist, I'm really respected for my drug knowledge. When I started consulting, when the definition of a consultant pharmacist was first derived, nobody knew what we were really responsible for. And now that's changed completely. Here's a question. Do you have suggestions on how to educate CNAs on things to report to nurses to prevent poor outcomes related to medications? Well, there are actually CNA education programs that are put out by organizations, including some of the drug companies, to educate the CNAs on some of the simple signs and symptoms. And a CNA should be aware of what hypoglycemia looks like, or what an opioid excessive dose, excessive effects looks like. These, obviously, their training is focused and limited pharmacologically, but just knowing some of the simple signs and symptoms, so they can call the alert, they raise up the red flag and alert nursing to evaluate the resident. How involved are your consultants in QAPI activities? Well, I'm an independent consultant, and I worked on the QAPI committee. To tell you the truth, this was the first facility that I had. My 40-bed skilled facility was the first facility I was asked to serve on the QAPI committee. I'd served on other committees, quality assurance committees, et cetera. But I was just part of the agenda. You know, I would look at the medication issues, and one of the simple things I did is look for holes in the MER to make sure everybody was documenting drugs were given. But basically, one of my big roles in the facility, one of pharmacists' big roles, is to keep you protected, primarily to keep the residents protected, but also to keep the facility protected from surveyor problems that are preventable. And we're always really getting you ready for the next survey and improving quality of care. I'm hearing the campus bells from the Carillon. It just looks like we're just about at noon. So Shannon, I thank you very much for inviting me. This has really been fun. Have a safe weekend, everybody. Be safe.
Yes, before you go, we are just asking you if you could please quickly fill out, rate your satisfaction with today's session. We'd love to hear your feedback and also any of your recommendations for things that we could do to entertain you during our Hot Topic series. If there's things you think are a hot topic that we should cover, please go ahead and do so. And thank you very much for those of you who are taking a moment to rate your satisfaction. While you're doing that, I will say thank you very much to Dr. Simonson. This was so great, and I know it's so much information in a short time, and we just really valued your wisdom today. Thank you so much for sharing that. Thank you. I encourage everyone to check out our posted webinars. I put the link in our chat for our hot topics for 2020, and also we have hot topics going back to 2018 as well, and be glad to send those to anybody interested. And thank you so much for joining us.